Good afternoon. Welcome to the program, Optimizing Treatment for Major Depressive Disorder, an integrative approach utilizing brain stimulation therapy. I'm Julie Miller, Editor-in-Chief of Addiction Professional. Today's program is sponsored by Sierra Tucson. Thank you to our sponsor and to everyone in our audience for joining us today. Before we get started, there's a few details that we'd like to go over with you. To submit a question or to ask about a technical issue, please use the Q&A area below the slides at any time. You don't have to wait until the end of the program to ask your question. To download a copy of the presentation, please click on the link in the Resources tab to the right of your slides. And a special note about CE credit. To get your CE, you must watch the program all the way through the Q&A section at the end of the presentation. At the end, do not leave the web page. The site will automatically redirect you to a survey. The survey must be completed in order to generate your CE certificate. For those watching in a group, please download the group submission guide in the Resources tab and follow the instructions provided. Please note that CE credit is not available for the archived webinar. It is only available for the live event. And finally, for those of you who tweet, please tweet along with us using the hashtag #APLiveWebinar. At this time, it's my pleasure to introduce our speaker for today, Michelle Chacon. Michelle is a certified TMS clinical operator and has been with Sierra Tucson since 2015. In her 20 years as a nurse, Michelle has worked in a wide variety of clinical settings. Her recent work has included outpatient and residential behavioral health, and she is passionate about the importance of mental health and wellness for all individuals. Michelle, thanks so much for taking the time to speak with us today. And with that, I will turn the audience over to you.
Oh, thank you, Julie, for that introduction. I'd like to welcome everyone today. With the holiday season approaching, this presentation feels very timely to me. Much has been written about the so-called holiday blues or holiday depression. And when we're talking about someone with major depressive disorder, the holidays and holiday-related stress might be a tipping point for a depressive episode, as stress is a well-known trigger for a recurrence of depression. So just to give an overview of what we'll be covering in the talk today, we'll start with a little background on depression, prevalence, burden of illness, some diagnostic information, and the challenges that that patients and clinicians face in treating major depressive disorder. And then we'll be talking about brain stimulation as a therapeutic tool for treating major depressive disorder. I'll talk a little bit about the background of neuromodulation, indications, and FDA versus non-FDA approved applications for brain stimulation. So as far as the prevalence of major depressive disorder, it is the most common of all psychiatric disorders. And this is really a major public health problem. I think it's compounded by numerous factors. There's the cumulative impact of genetics, things like neurobiology, childhood trauma or adverse events in childhood, developmental trauma, I guess, ongoing or recent stress. The 2012 World Health Organization Global Burden of Disease Survey ranked depression as the fourth leading cause of disability worldwide. Why do we care about this? It's important that we understand that in this century, depression will be second only to ischemic heart disease as a leading cause of illness in the world. And in spite of so much research, decades of research, public awareness efforts, attempts at intervention that have been very widespread, the rates of major depressive disorder, the prevalence of it remains stable. Furthermore, the antidepressant medications that are out there, there are more than there ever have been. They're being prescribed at an all-time high. They haven't demonstrated a significant efficacy or even a consistent advantage over placebo. And while psychotherapy is certainly effective on numerous fronts for treating major depressive disorder, there's an issue of patients not being referred for it or insurance not covering it. So there's major gaps in treatment for this disorder. When we look at the burden of depression, the mortality risk for suicide in depressed patients is more than 20-fold greater than the general population. So this is key. There's also major relationship between major depressive disorder and chronic illnesses. And so the interesting thing with that is that those relationships between MDD and chronic medical conditions appear to be bidirectional. The influence of one may have an effect on the prognosis of the other. Some of those things that really we can key in on are, say, diabetes, heart disease, or cardiac disease, and substance use disorders. Certainly, when we look at the issue of major depressive disorder and how it impacts people with cardiovascular disease, depressive symptoms are associated with a very high risk of mortality with cardiovascular events. One study showed that in the 12 months following cardiac catheterization, major depressive disorder was the single biggest predictor of a heart attack, angioplasty, or death. And so there's a huge risk there in these folks that have comorbid depression with significant medical issues. As far as the financial impact, the economic burden of adults with major depressive disorder is huge and growing. And then the social impact, certainly impaired relationships with the poor parenting listed there. A study of children of low-income depressed women reported that those children have 3 times greater risk of serious emotional or behavioral problems. So this is something that impacts far more than just the individual that has depression. And so these things are just the tip of the iceberg in terms of the burden of depression. When we're looking at comorbidities with major depressive disorder, it spans everything from cognitive disorders, again, the cardiovascular disorders, even immune disorders, HIV, again, the diabetes, the cancer, the Parkinson's. So there are some very significant overlapping issues with those disorders. Just a quick review, though, of the diagnostic criteria for major depressive disorders. This is all just directly from the DSM. Essentially, one of those symptoms must be depressed mood or loss of interest. Those are highlighted in red. So if there are 5 of those present for a 2-week period, then, additionally, if the symptoms cause clinically significant distress or impairment in other important areas of functioning, such as work or socially, and also the episode, is not something that can be attributed to substance use or other medical conditions, and there's never been a manic or hypomanic episode, then this is really where those people would fall in terms of the diagnostic criteria. So we're looking at these, and certainly that's pretty comprehensive. In terms of standard treatment, when we're looking at treatment for persons with major depressive disorder, the challenges that arise often come from, number one, the poor recognition. So these are the patients that will present to their doctor's office with purely somatic complaints, vague complaints of headache, body aches, things like that, or difficulty with sleep. So rarely are they talking to their doctors or their medical providers about mood or sadness. So a lot of times this is not recognized by the medical provider as potentially being a major depressive episode. Additionally, there may be, and certainly is, some stigma that surrounds a diagnosis. So this is where the patient, the individual, may try to focus on only the somatic issues and downplay or minimize, the sadness or the loss of interest in those symptoms. With one study, there was 69% of people that presented to their primary provider reported only somatic complaints. And so this can make it difficult for clinicians to identify and diagnose, and then to initiate appropriate treatment. So the other thing is that the clinical picture is going to vary. So what depression looks like can change significantly. And certainly, due to the disorder itself having episodes of remission and then relapses in symptoms, it may be that the point in time when the patient is presenting to the medical provider that symptoms may not be present. Another issue in treatment is that these mood disorders can tend to be placed on the back burner by medical providers, especially in the presence of significant medical comorbidities. If someone has some metabolic syndrome, heart disease, obesity, type 1 or 2 diabetes, those things will get prioritized at times over the mood disorder. And in primary care, the focus of treatment oftentimes is going to be on the somatic complaints. So what's going to be addressed? The sleep disturbance, the appetite, things like that, the back pain, the headaches, the fatigue. So really the somatic complaints are probably what's going to be addressed versus the mood symptoms. So these are some of the challenges. Of course, it's not a complete list, but that's certainly where providers and practitioners will have some difficulty in simply, treating or even identifying patients with major depressive disorder. And, in reviewing the treatment goals, the goal of treating major depressive disorder should always be complete remission without any residual symptoms. And so the definition stated here, 4 weeks, asymptomatic, without any residual symptoms. And residual symptom resolution, is important. And the reason for that is because that indicates that the episode is not resolved. It's important to identify remission and transition out of an episode correctly, because a major depressive episode with the continued presence of depressive symptoms poses a greater risk of relapse and indicates a quicker relapse into a major depressive episode, and it predicts a more severe chronic relapsing form of the disease. So people that have residual symptoms, say they're being treated for depression and their response to that treatment is subtherapeutic, so they feel improved but not quite into remission. If there are residual symptoms, the studies show that they will relapse 3 times as fast compared to those who were completely asymptomatic at remission. So it's really important to make that distinction and also to make that the goal for treatment for every patient. Essentially, residual symptoms boils down to more recurrence of episodes, contribute to poor medication adherence, patient frustration with treatment, and an overall lower quality of life. So that certainly is a lofty goal, but nonetheless, it should be the goal. As far as treatment strategies, so this is where we get into treatment for depression, starting with the pharmacologic. Your first line antidepressant medications will be, of course, your SSRIs, SNRIs, etc. For those with potentially refractory depression, augmentation strategies may be brought on board, and so this is where we bring in the antipsychotics, the mood stabilizers, even nutritional, folate, or and then I even listed the ketamine here, which is investigational. So there's no FDA approval for use of ketamine to treat major depressive disorder. However, it does show some promise due to it having such a rapid onset of action when given at subanesthetic doses. But so we include all that in the pharmacologic treatment strategies for depression. Then we kind of look at the focus of pharmacologic treatment for major depressive disorder has been focused on, the neurotransmitters, the serotonin. It's been looked at as a chemical problem, serotonin, norepinephrine. But we need to remember that depression is certainly far more complex than serotonin or norepinephrine, or simply it doesn't account for multitude of other influences, like genetics, genetic polymorphisms for emotional dysregulation, HPA axis dysfunction, so stress, inflammation, cortisol. Dopamine is increasingly thought to play a very important role in major depressive disorder and the pathophysiology. Certainly, it makes sense that dysfunction in the dopamine feedback system may underlie anhedonia, complete loss of interest in patients with major depressive disorder. Other neurotransmitters, like GABA, neuropeptides. As we're talking about substance P, endorphins, corticotropin releasing hormone. There's numerous other chemicals involved, and certainly abnormal brain activation patterns. And so that, which certainly can be visualized on functional MRIs, PET scans, the downregulation, the deactivation that's present in major depressive disorder. There's a lot of evidence that there's some abnormalities in the connection between cortical and subcortical regions of the brain, including the limbic system, and the list goes on, but certainly illustrates the need for additional therapies besides drugs or simply the pharmacologic treatments. And so when we go, can we get to the next slide, please? Oh. Thank you. So when we are looking at the STAR-D trial, I did include some information on the STAR-D, which is a sequential or sequenced treatment alternatives to relieve depression. This was a 2006 study that essentially involved 4,000 patients. It was funded by the National Institutes of Mental Health and was at multiple sites. And it was designed to simulate real clinical situations. So the study, the patients, it was not blinded. The patients had input into treatment decisions. Essentially, the outcomes of that were, which I'll get to the next slide, but it was a very large study. Kind of the thrust of it was that it was a decision tree. Every patient started out on the first level with citalopram or Celexa as the antidepressant. If that was not effective, then they would be randomized into different study arms. If the citalopram wasn't effective and at level 2, they could switch to sertraline, or they could switch to an SNRI, so they would be switched to Effexor, or they could switch to therapy, cognitive behavioral therapy, or augment with Wellbutrin or Buspar. And so if that didn't work, they would switch again. So at the third level, they would be randomized into an arm where they would switch to mirtazapine, or this is where they could bring in a tricyclic, so they could factor in nortriptyline, or they could augment with lithium or thyroid. And then certainly with the fourth level, so this would be the level where they would stop medications and kind of start over. They could do a washout and start a patient on an MAOI. So that was really only an offering in the final level. Or they could do a mirtazapine Effexor combo. So basically, it was stepped, and so that is essentially those levels that we see there. And so essentially the efficacy and the outcomes with the STAR-D trials, I think the takeaway there is that by the time you get to the fourth antidepressant or 3 prior treatment failures, there was a 6.9% chance of remission. And so really none of the late sequence treatment options emerged as any sort of miracle intervention for patients with refractory or treatment-resistant depression. Essentially, if patients have failed two treatment interventions, if once they've come to their third or fourth, then really only modest results can be expected. In the successive trials. So this is where at this point, the diagnosis of treatment refractory depression would probably come on board, and essentially that's failure to have an adequate response to an adequate trial at an adequate dose. So we're talking about a subtherapeutic response, or there's still symptoms. Inadequate trial, meaning 4 to 6 weeks at a therapeutic level, not a starter dose. And so once we have folks at that point where they are on their third or their fourth or their fifth, or augmentation strategies are being brought in, there statistically really is not a lot of reason to be optimistic with medications. This is kind of why looking towards treatment alternatives, neurostimulation, is something that is certainly being looked at, not just for depression, but for numerous, not only psychiatric conditions, but medical conditions as well. When looking at medication adherence, and that's what this chart sort of highlights, that there's more likely, there's a bigger likelihood of patients experiencing side effects with each treatment failure, or dropping out of or stopping medication, discontinuing medication, simply because the medication is not working, or they have lost confidence in antidepressants to be able to help them. Side effects, certainly will lead to non-adherence in a regimen. And again, patients frustrated with the lack of efficacy, maybe starting out hopeful and then, taking a medication for 4 to 6 weeks to find out that it's not helpful, or that the side effects are intolerable. This is kind of what happens. And so this statistically, that the longer that we try to, and the more medications that are sort of prescribed at this point, the greater the likelihood of a patient actually discontinuing the treatment regimen. And certainly psychotherapy is effective, but again, patients are either not referred for psychotherapy, or there can be issues with lack of insurance coverage around psychotherapy. And as far as medication I think a lot of times what happens as well, and this is something that I hear frequently from patients with major depressive disorder, is that the medications, they may be on their fourth or their fifth or antidepressant, and this is the second or third antipsychotic that they've had as an augmentation strategy. They may have some response with those medications. They may have found some sort of drug regimen or cocktail, if you will, that is offering some relief to them. There are residual symptoms, but they will continue this regimen because, they've found something that maybe is marginally more tolerable than what they were taking previously. But and countless times you hear, I don't feel happy, I just feel blah. I don't really feel anything. So there are some downsides with the medications that, especially, individuals who are treatment refractory will sort of echo some of the same things over and over again as far as, the medications, the side effects, what they tend to experience. And it's almost as if they're treading water and certainly working towards not feeling suicidal for the moment. And even if it involves a regimen of 5 or 6 drugs and, some side effects that, it may be better than, say, the alternative, which would be feeling suicidal or having a death wish, etc. And as far as side effects, I thought this was very cute. So, and this can be true of any class of medication, not solely antidepressant medications. Looking at neurostimulation therapy or brain stimulation, what this is essentially is modulating the nervous system by electrically activating neurons. This is modulating cortical excitability. There are 3 ways that this can be achieved. Through surface electrodes, such as ECT, where electrodes are applied to the body, or TENS units. Implanted electrodes. This requires surgical intervention, VNS devices, deep brain stimulators. And then there is indirect stimulation, and that is through an energy field, essentially, which is what TMS is, or magnetic seizure therapy. And so it's essentially what magnetic seizure therapy is super TMS, which is a magnetic field, but it is designed to induce a seizure. And this isn't certainly not a complete list of neurostimulation, but this is sort of an idea of what how we can classify neurostimulation. And it's important to remember that in terms of modulating the brain is an electrochemical organ. So it can be stimulated or modulated through chemicals or drugs, altering neurotransmitters, and that's done with medication. Then there's the electrical aspect of the brain. And so that piece is what neurostimulation or neuromodulation focuses on. So the question that I get quite a bit is TMS the same thing as ECT? And so there's some significant differences between ECT and TMS. Electroconvulsive treatment, needs an electric current. But as it turns out, electric current is painful, so that requires general anesthesia. It is a convulsive treatment. It's designed to induce a seizure. There's some differences in the treatment course. Onset of action is going to be rapid with ECT, 2 to 3 treatments. but there's a massive release of neurotransmitter and in the brain with the seizure that's induced. Some side effects that are possible with ECT, the retrograde amnesia, confusion, so the cognitive outcomes there have been studied. TMS is a magnetic field, and a magnetic field is able to penetrate through the cranium to the cortical tissue to the brain without needing anesthesia. So the patient is awake during the procedure, and it is non-convulsive. This is not designed to induce a seizure. Again, differences in treatment course, and the onset with TMS is going to be slower. So the results, it may take 15 to 20 treatments to see the therapeutic action. The way that TMS works is that it activates neural circuits for local release of neurotransmitters rather than that massive release that occurs with ECT. The side effect profile is much different as well, and so most commonly scalp discomfort, which is superficial, transient, headache, again, transient. But one of the best things about TMS, or transcranial magnetic stimulation, is that it's pro-cognitive. And so the cognitive outcomes there are certainly there's no long-term deficits, but then there are there's a budding research base that shows that TMS potentially improves cognition. There's improvement in memory, visual recall, and then with TMS there are no systemic side effects, which is appealing to patients who have experienced numerous side effects with antidepressant medications, or certainly have experienced the side effects of augmentation medications with the antipsychotics, the weight gain, et cetera. So that certainly can be appealing. But when you contrast ECT with TMS, essentially the side effects alone would really lend itself to, looking at TMS as an option or a treatment that would be used earlier in the depression care pathway, sooner than ECT, if we're looking at treatment on that sort of spectrum in terms of the brain stimulation treatment. The way that TMS works is that it's a magnetic field that causes depolarization of those cortical neurons, and so neurotransmitters are released, and it talks about activation of neural circuits. And so the basis for TMS is Faraday's law of electromagnetic induction. So a magnetic field has a very close relationship with an electrical field. Essentially, they're very much interchangeable. So the magnetic field actually induces tiny currents, and this is what causes a neuronal depolarization. And so that is what happens during TMS. The nice thing about TMS is that it actually takes advantage or utilizes the circuitry involved with the brain as seen in major depressive disorder. So the site of stimulation is the dorsolateral prefrontal cortex. Essentially, for depression, the stimulation site would be the prefrontal cortex, but there is a connection with deeper structures in the brain. That limbic structure that is involved heavily in mood is really where, I guess, the magic happens with TMS. Certainly, there's locally there's increased blood flow. There's increased glucose metabolism right at the site of stimulation. But then the TMS ultimately, the stimulation upregulates brain-derived neurotropic factor. There's an ongoing release of neurotransmitters, and the basis of TMS being effective for depression is that repeated, frequent sessions result in changes overall in neuroplasticity, and so there can be an effect, and it can affect long-lasting changes. In terms of the outcomes, there have been numerous studies supporting TMS for major depressive disorder. And, as far as brain stimulation goes, ECT, of course, is still considered the gold standard for brain stimulation therapy for major depressive disorder. The superiority of ECT, though, is more apparent only in psychotic depression or in depression where there's catatonia or there needs to be acute measures or significant measures taken for very acute depression, suicidal depression. For major depressive episode that has not responded to 1 or 2 or 3 or 4 antidepressants, that is not where the patient is not acutely suicidal, TMS actually has been shown to be as effective as ECT. And so that was a 2014 meta-analysis. So those are recent results. So TMS is comparable to ECT as far as efficacy. And so, which is important to because I think that what happens is that most times when I talk to patients about TMS and explain how it works and where it fits in, there are patients who have never heard of it. They may be contemplating ECT, and so working that into the toolbox for psychiatric practitioners is something that we're hoping to get more knowledge out there as far as that this is a viable and validated treatment for major depression, scientifically validated. It has FDA clearance. And it was included in the 2010 APA guidelines as a second-line treatment, so it's right up there with light therapy, cognitive behavioral therapy. So really the idea here is that the patient does not have to have treatment refractory depression. They do not have to have treatment resistant depression. So second line, failure of one, a minimum of 1 up to 4 antidepressants is really all that's required for someone to be considered a candidate according to APA guidelines. It's also indicated prior to atypical antipsychotic augmentation, which is great news for patients who do not tolerate antipsychotic medications well, or side effects that go along with that. So the CPT codes for TMS are 90867, 90868, 90869, and most major insurance carriers do cover TMS with certain restrictions and exclusions, and largely it's going to rely on documentation of failed medication trials. With insurance coverage for TMS, the major carriers include policies that cover TMS as a treatment for major depressive disorder if there is sufficient documentation that first-line strategies have failed, meaning anywhere from 1 to 4 antidepressant medications, for therapeutic duration at a therapeutic dose, and 12 sessions or so minimum of therapy or cognitive behavioral therapy. And so this is promising as far as having insurance coverage. We move to the next. So we move to the next slide. Okay. Oh, so here's who can benefit. And so this is really kind of a profile of who would be someone that could benefit from brain stimulation for depression, neuromodulation. This is someone who has tried numerous antidepressants and has not experienced remission. And again, we're looking at remission as the goal. And the patient, potentially may have a very complex drug regimen, or maybe considering a complex drug regimen involving several antidepressants, an antipsychotic, etc. And or the individual who is very much sensitive to medications and experiences numerous side effects. Certainly with TMS, the individual should have no metallic objects or implants in or around their head, or pacemaker, medical implants, and other contraindications would include things like history of stroke or aneurysm, recent brain injury or history of traumatic brain injury, epilepsy, brain tumors. So, and this is not a comprehensive list of contraindications, but this is the starting point, at least for treatment with TMS. And, briefly I wanted to touch on, TMS and research into other areas. So the FDA-approved indication for transcranial magnetic stimulation currently is for major depressive disorder. But there is some emerging research and studies being done around numerous conditions. For example, fibromyalgia, schizophrenia, depression and pregnancy. And this could be a game changer since there really is not a whole lot of really great antidepressant options for patients who are depressed and who are pregnant or nursing. So there are clinical trials underway now. PTSD, binge eating disorder, bulimia nervosa. There are quite a few different studies that are going on for a lot of these different conditions, and to highlight the future of TMS and where TMS is headed, or brain stimulation. This was a study in which TMS was administered and found to be effective. So these are pilot studies. There's certainly a lot more research that needs to be done. And for any substance use disorder, neurostimulation is still considered investigational. And yet the idea here is that it has huge potentials in terms of treating cravings, in terms of treating behavioral components, and combined with cognitive behavioral therapy or psychotherapy, there's an amazing potential that certainly it needs to be explored and more well researched. And in this year in September, this National Geographic did feature TMS heavily on reported a study that was going on that actually was around TMS and cocaine addiction that had very positive outcomes. And so again, it was a pilot study, but you know, addiction being such a common, highly comorbid and disabling disorder that largely goes untreated, current statistics on morbidity and mortality indicate a very urgent need for additional studies and research for new treatment modalities and to incorporate emergent research on neurostimulation that takes into consideration brain connectivity and neuroplasticity. This is potentially could be the future of addiction treatment, and so that may be where things are headed. And I thank you all for listening, and I think we're ready for Q&A.
Okay, great. Michelle, thank you so much for your insight. We have had a number of questions come in from the audience, but you can go ahead and use that Q&A area below the slides to submit a question. Also remember to download a copy of the slides. Please click on the Resources tab to the right of the presentation window. Okay, Michelle, let's dig in. Can you talk about how frequently someone can receive TMS?
The typical treatment course being 20 to 30 sessions, which is 4 to 6 weeks. The idea is to have someone go into remission, and retreatment would be indicated if symptoms return. And so generally what that means is that I think that for insurance coverage purposes, what I've seen is that 6 months has to have elapsed before they would cover another course of therapy. So largely it's driven by symptoms, or emergence of a depressive episode. But for insurers, a lot of times what they require is that they will cover retreatment if someone has successful therapy from a first course, but then I think 6 months has to have elapsed. I hope that answers the question.
Absolutely. And how long do the benefits of a full course of treatment stay effective for an average patient?
Well, the most recent data that I have available to me shows that in a 12-month follow-up or 1-year follow-up that for those who entered remission, those patients that it was more than 60%, 67%, I believe, maintained that remission for a year. So symptoms did return in 30-some odd percent of patients. And so that, again, is the most recent statistics that I have available to me. But I would say in general, 2/3 or better will have maintain their remission or maintain the benefit for a year or more.
Okay, great. And if someone doesn't find that a full course of TMS is successful for them, what is typically the next recommended step? Do you try it again? Do you wait a while? Do you look for another treatment?
So it's a sort of collaborative approach, and I would say that in looking at brain stimulation, certainly when I had mentioned that TMS should be considered earlier in the depression care pathway than ECT, ECT is still certainly a viable treatment option for treatment refractory depression. It certainly would be something that the patient would carefully need to take into consideration based on side effects and the potential for, again, retrograde amnesia, the cognitive deficits, or the potential for them. So certainly that is another option. If we're looking at FDA-approved treatment strategies for major depression, there's also deep brain stimulation or VNS devices, and then off-label, you're looking at things like the ketamine. So, I would say there's probably not an endless or infinite amount of treatment options, but certainly with working TMS into the equation, if it's not successful for someone, if they do a full 6-week course, I don't believe that there's any benefit for them to repeat it. So they would probably move to the next treatment option that they discuss with their practitioner.
Okay, that's good advice. And can you talk about the different populations that could be treated with TMS? Is it safe to use with teenagers, adolescents, children, older adults? What kind of information do you have?
So in terms of the, since this is an FDA-approved therapy, it is approved for, the patient population that it was tested on in clinical trials. And so we're looking at adults, and I think they consider that age 22 up to 65. So as far as adolescents, clinical trials are underway with the manufacturer of one of the devices for that population. And there is really, as far as safety concerns with TMS, the side effect profile is excellent. It's very well tolerated, and so I'm aware that there are TMS clinics and TMS practitioners that do offer treatment to adolescents or patients outside of that population group, or that narrow range of age between, I think, 22 and 65. What I can tell you is that, for most practical purposes, what excludes someone from being able to do TMS is going to be, again, like any metallic objects or implants in the head or neck, pacemaker, or implanted cardioverter defibrillator, or epilepsy.
Okay, that is all the time that we have for questions today, but we do have some final instructions regarding CE credit. Please do not leave this page. Continue to stay on the platform. This site will automatically redirect you to a survey. This survey must be completed in order to generate your CE certificate. And as a reminder, for those of you watching in a group, please download the group submission guide, which you'll find in the Resources tab to the right of the slides, and follow the instructions provided. Again, please note that CE credit is not available for the archived webinar. It is only available for the live event, November 8th, 2017. I would like to thank Michelle Chacon once again for a great presentation, and I would also like to thank our sponsor, Sierra Tucson, for making today's program possible. And finally, thank you to everyone in our audience for participating today. We do hope that you will join us again in the future for another Addiction Professional webinar. This concludes today's presentation.